Hello, everyone. I'm Syamala. What's up? Today, Hyunmin and I will be talking about behavioral health and government regulation in the United States. So, quickly, over the past couple weeks, Hyunmin and I have done a ton of research and reading up on behavioral health in the US. So, we still have lots of questions. We don't claim to be experts in this topic, but behavioral health is an evolving discipline. And today we'll be sharing some potential solutions that we think could help mitigate issues that are prevalent in behavioral health. But first off, what is behavioral health? So the term behavioral health is defined as the promotion of mental health, resilience, and well-being, the treatment of mental and substance use disorders, and the support of those in recovery from these conditions, including families and communities. Wow, that's a lot in just two words, but in order to properly address the stigma surrounding behavioral health, let's unpack what that definition really means. So let's take a second to think. What are our first reactions to behavioral health? What do we think of when someone says the term mental health or therapy? What kind of connotations and stigmas are implicated with the phrase? Almost everyone knows someone with a behavioral health condition, whether it's depression, anxiety, or substance abuse, but very few have considered how behavioral health has a significant impact on every other area of an individual's life. Like, did you know that nearly every five Americans are affected by a behavioral health disorder, or that mental health diagnoses are associated with 7 to 24 years of reduced life expectancy? And if this is the national average, how do behavioral health issues impact more vulnerable communities in this country? If you are a person of color, served in the military, are LGBTQ+, have a physical disability, or any combination of the aforementioned, then these people are much more likely to suffer from behavioral health conditions as well as high rates of suicide. Yet, only 25% of patients actually receive effective mental health care, including in primary care settings where the majority of patients with mental health or substance use receive their usual care. So, you have a question?
What is the source for the 25% getting proper mental health care?
The source was, I think,
report from American Hospital Associations.
Okay, yeah.
Yeah, but we can check after.
An AHA type stat. Thank you.
Great question. So where was I? One sec. Okay, yeah. So now you're probably asking, well, if behavioral health is so important to a progressive, healthy society, why isn't the healthcare system set up to prioritize behavioral health? And this is where things can get a little tricky, because the problem with behavioral health system has to do with something called misaligned incentives. So there are three different perspectives to consider when analyzing the healthcare system and its ability to effectively provide care while still remaining profitable to those providing services. Each party has an incentive for participating in the system. The first and most important perspective is the patient. The patient is supposed to get healthier, right? So their only incentive is to get care and treatment and benefit from a healthier life. Then you have the providers, like doctors and hospitals, who work in partnership with patients to give the actual care that they need and are reimbursed by payers, which include insurance companies that some people receive through their employer or Medicaid. Payers are responsible for reimbursing providers for the cost of services. But in behavioral health, this system starts to break down. So behavioral health is an essential, expensive, and long-term service, but it is not profitable in the short term, which Hyunmin will talk about more in a second. But it covers so much from social workers to psychiatrists to hospitals, medication, and more. And since so much money is going to the service, but the profits can only be seen long-term, providers actually lose money by providing behavioral health services right now, even if long-term they can save.
Help me understand, you only see profits long-term.
Yeah, that was something that we're going to talk about more later.
Cool.
But should I talk about it now?
No, if it's coming up, I think that's totally cool to just say, hold your horses.
Hold your horses, Adam. All right. So then we're left with the stigmas of mental health, and the cycle continues.
So to address this vicious cycle and turn it into something better, multiple studies have looked for ways to address this, and one theme stands out, which is increased access to behavioral health. Models that increase access through incorporating behavioral health into other medical settings have been shown to improve quality and lower cost. So, for example, if you co-locate primary care and mental health care services, it not only allows people to access behavioral health services while maintaining their daily lives, but it also lowers the psychological barrier to receiving treatment. So as a result, more patients are treated early on, and they're more likely to stick to their treatment.
Am I understanding correctly? If your behavioral health provider is in the same building or in the same set of offices as, let's say, your primary care doctor, you are more likely to seek care just because there's a lower barrier to entry?
Surprisingly, yes. From what we've read, because currently, like, the behavioral health care service is predominantly provided by specialty clinics. So it's siloed from the primary care. So the psychological perception of behavioral health care is something extra, or like something that is not part of your essential health, basically. So that simple co-location has proved to be helpful, and there are other ways to integrate behavioral health care into primary health.
Well, and it makes perfect sense, too, because even if you believe your behavioral health care is an essential service, but yet you have to take a different 1 hour break from work than you took to go to your doctor's office and travel to a different location across town, just those tiny little barriers can stack up. It makes sense to me.
Yeah, absolutely. So yeah, increased access definitely improves the outcome of the treatments, and it also lowers costs. So when people have more ready access to behavioral health care, they receive early and perhaps preemptive screening and treatment. So the providers have less burden of expensive acute services like emergency department visits. And if there's an inpatient service, the patients are likely to stay shorter, so it further reduces the inpatient cost.
So is there evidence for these assertions? So you're saying shorter length of stay, and you said also, is there a lower cost other than shorter lengths of stay?
Yeah, absolutely. What we read was like a compendium of case studies done on, and it's in the 2019 trend report, one of the major papers that we've read, and you probably know about that too.
Cool.
We just wanted to make it more simple and anecdotal for the purpose of the presentation.
Sure.
Yeah, so now we know that behavioral health works well when connected with primary care. So the ensuing question would be, will increasing access via integration of behavioral health care help align the messed up incentives in the healthcare system, behavioral healthcare system? So to try to address this question, let's go back to Adam's presentation, I think 2 weeks ago. One of the things that we noticed on Adam's last presentation was the fact that mental health care service is so costly and unprofitable for the providers that if given a choice between cardiovascular intervention and mental health therapy, the providers are incentivized to choose the former, which made us launch into this thought experiment of like, wait, Adam said providers in healthcare have fundamentally misaligned incentives because the sicker the population, the more service they give out and the more money they make. But if each service is incurring cost, then the providers are actually incentivized to promote behavioral health so that they can do less of these unprofitable practices and ultimately reducing the overall cost of healthcare. And of course, the providers can just turn a blind eye to behavioral health altogether and incur no cost. But we'd like to maintain our faith in the goodwill of healthcare providers and assume that they will not stop trying to enhance population health. They're just extremely agonized. Now we have entertained the possibility of the incentives aligning in behavioral health care. The natural question would be, to what degree will they align if they do so, and is it significant enough? To look at the impact of improving behavioral health, we can take the DAILY score, a reference point. So DAILY score stands for Disability Adjusted Life Year. And it's a rough measure of the total disease burden, which in other words is a burden that can be relieved by better treatment. It's a sum of years of life lost and years lived with disability. Years of life lost is obviously a big loss and is associated with expensive acute care like emergency visits. With years lived with disability, the patient lives, but perhaps with recurring healthcare cost that is less deteriorating. Surprisingly, the DAILY score for behavioral health conditions is the highest of all categories of healthcare. And not so surprisingly, after hearing this, the U.S. healthcare cost was the largest in behavioral health, which was around $200 billion. And if you compare this with the $50 billion used in heart conditions and $80 billion used in cancer, you can see how big the cost is. So we can see that addressing behavioral health can relieve a lot of cost burden for the providers.
So sorry, why does adding disability or losing life add cost?
I think The cost comes from, like, I think it's twofold. We think promoting health and longevity is also an incentive for the provider because it's healthcare industry. Also, years of life lost, we think, is associated with more expensive treatment events.
I'm not sure I buy it because, all right, so in a really cynical world, we would say if a patient dies, then they don't incur any further medical costs. So that's why I'm curious about a financial benefit. So first of all, years with disability makes total sense. Person with disabilities more likely to have higher healthcare costs for a variety of reasons. So if we say it's mostly about the disabilities, then I think I agree with it.
Well, this thought experiment was unfortunately based on our assumption that years of life lost has stronger associations with expensive care. But maybe if we hear out the details of like what I'm about to say, will maybe cater to what you're thinking.
Well, and I'll agree with one thing, which is end of life care, especially for a person who does not have like an advanced health directive, end of life care can be extremely expensive. So there is that, but patient can only die one time. So the number of years lived, that's a tricky one. Yeah, please walk through the example.
Yeah, like one assumption that I kind of associated with this thought experiment was that reactive healthcare is more expensive than preemptive healthcare. So like with that like simple model in mind, that's how I constructed the example. But honestly, I'm not sure how accurate this would be. So.
Right. And I think in general that maxim holds true and the devil's in the details.
Yeah. So I'll just get back to this example.
Yeah, please.
So years of life lost and years lived with disability. If more people with serious mental illness are treated, then theoretically years of life lost decreases and years lived with disability increases, meaning the cost of healthcare reduces in amount and are spread more thinly. You can disagree with this. And with better healthcare, the overall cost reduces too. So the cost would more look like the bottom bar. And as behavioral health becomes profitable at all, this could also mean that the providers will have a long-term revenue stream that promotes patient population health at the same time. So this was our thought experiment in thinking why behavioral health would matter at all for each party. So yeah.
No, I appreciate that. And I do just want to set the record straight. So I put out the negative $50 number, which I think was directionally accurate for a large health system, according to my experience. But I'll just to make it clear, there are a lot of behavioral health providers who are profitable. And, I'm thinking of my wife who works in a private practice therapy office. They are all 100% behavioral health providers and they turn a profit on most patients. So I think it might be slightly oversimplifying to say that behavioral health is unprofitable, but I do think it's hard to prioritize at a large health system when there are so many more profitable directions to go or services to focus on.
If the details align with the argument, then this might be a good case for large institutions to invest in behavioral health care.
Mm-hmm.
All right. So now let's go back to the stigmas surrounding behavioral health. So when we think about the things that influence us, there are some standard facets that come to mind, like friends and family, media we consume, our school. But what about government? Like the literal people who write policies and decide what is lawful or unlawful. How does that relate to healthcare? Is it lawful or unlawful to provide healthcare for the people of a nation? Is it lawful to promote healthy choices and a healthy lifestyle? When we think about ways in which the government can help promote behavioral health, there are a few ways in which this could happen. Not only is it lawful to promote prioritization of a healthy society, but we believe it is the government's responsibility to do so. And I know that some of you may disagree with how the government should play a role in the health of the people, but when we say life, liberty, and the pursuit of happiness, that includes life. And I would encourage folks watching this to take a second to reflect on what your perception of government is. And I don't mean just U.S. government, I mean government in general. Where did our understanding of government come from? The government itself, private corporations, through government officials? All of this is to say behavioral health functions differently than other areas of healthcare because these conditions impact people differently and for different reasons. An investment in behavioral health is an investment in a healthier, happier, safer society. Environment and other social determinants also play a key role in actual behavioral health utilization. The field intersects with so many different areas, such as the criminal justice system, housing, employment, education, and more, which are also factors that disproportionately impact minority populations. There's more to behavioral health than just mental health, although that is a crucial part of it. And this is the point where the government has a responsibility to step in and provide equitable access to behavioral health and keep people informed about them.
Okay, what would you say to somebody who argues that previously marginalized populations already have equitable access to behavioral health because, let's say they're on Medicaid. Medicaid reimburses behavioral health care the same no matter what your race is.
Okay, so I feel like when it comes to that, that is also, that is very detailed and like long historical institutions of systemic racism that will not just be solved with simple, like not simple, like Medicaid's not simple, but like will not be solved by one government program. And so I would say that it's not as easy as just providing reimbursement to low-income populations. And also like it's more than access, it's also about like promotion. And like just because people qualify for Medicaid doesn't necessarily mean that they're on it also. And so I guess I'll just stop there before I go on a tangent. But
no, you're good. One thing that comes to mind is Hyunmin's previous point that when behavioral health is integrated with primary care, people are more likely to use it. And so this just gets to it suggests about how subtle the friction can be that would turn someone off or would make someone not pursue behavioral health. And so, if we think about what's affecting some communities and making them use less behavioral health, some of the friction might just be have to drive farther, can't afford to pay it out of pocket, or even my dad will think I'm a wimp, like that.
Right.
So all of those could play a role in not pursuing behavioral health. And speaking of the government's role, if we knew for a fact that, so we're the taxpayers, we're the stakeholders here in this system, and if we knew for a fact that a certain person would be really costly to take care of 10 years from now if they don't have behavioral health care, but they would be really affordable to take care of for the next 10 years if they do have behavioral health care, wouldn't we want our government to do a small minor intervention to make that person cost less for everyone?
Yeah, you would think. Yeah, no, great point. Sorry, should I continue?
Yeah. That was all I had on that.
Okay, cool. All right. So we know that every year the healthcare system invests billions of dollars in behavioral health to provide care and social services that save lives and hopefully encourages people to maintain a healthy lifestyle. However, as Hyunmin just explained, there is little short-term profit in investing in behavioral health. And long-term, behavioral health actually helps reduce costs and improve health. And behavioral health conditions and treatment require constant and consistent care that can span over years or even decades. Treatment and medication will always vary from person to person and require attention from different health providers to improve and maintain healthy behavioral habits. It's not much different than your physical health. When you want to lose weight, you will go to the gym and maybe eat a healthier diet. And after you've lost weight, do you just go back to never exercising and eating junk all the time? No, because then you'll just become unhealthy again. You have to maintain your weight by consistently eating well, exercising, and yes, going to the doctor. Behavioral health works in the same way. In fact, professionals have thought about the link between physical and behavioral health already and put it to work through the Medicaid Physical and Mental Health Integration Initiative. Approximately 1 out of 5 Medicaid enrollees live with a diagnosed mental health condition or substance use disorder. Patients with psychotic disorders represented the top 2 most common diagnoses for rehospitalizations among Medicaid beneficiaries in 2011. Because of the prevalence of behavioral health issues and the high spending on behavioral health care and Medicaid, initiatives to integrate physical and mental health are a top priority for Medicaid agencies. Since April 2016, Medicaid collaborated with states to improve physical and mental health, or PMH, integration efforts. There are 3 A's to address the impact of each behavioral health initiative passed by the government. These 3 A's consist of awareness, assistance, and alignment. So awareness, this Medicaid physical and mental health integration tries to address awareness by improving the behavioral and physical health outcomes and experience of care for individuals with mental health conditions. And they utilize assistance through the creation of opportunities for states to link payments with improved outcomes of Medicaid beneficiaries to address the connection between physical and mental health, and alignment through expanding existing state PMH integration efforts to be inclusive of vulnerable populations and spread integration efforts to new areas of the state or to new types of health professionals.
Under this integration initiative, there has been some changes in the behavioral healthcare industry. One of the tangible changes is how CMS payment for behavioral healthcare has changed. So starting from January 2017, providers have been able to bill CMS for psychiatric collaborative care programs, which Syamala will explain in a bit, and behavioral health integration services. And please excuse this wall of text. I couldn't find a good way to abstract this. So this includes not only the actual treatment event that can be reimbursed, but also the management services that are aimed to enhance coordination, adherence, and effectiveness of treatment. The payment scheme addresses a major financial challenge that behavioral healthcare providers have been facing, which is the lack of reimbursement. As we've seen in the previous slide, behavioral healthcare involves a lot more work outside the actual face-to-face treatments than physical healthcare does. But because this kind of behind-the-scenes work were not acknowledged enough, they have been reimbursed 20% less than physical healthcare providers for their work. So this change in payment scheme can be an example of a change that addresses assistance, amending payment system so that it acknowledges the reality of the behavioral healthcare system and encourages more holistic. So we're 3 years into this program and we can't be sure how much of this financial gap has been built, but it definitely is a step in the right direction.
All right, so next we have the collaborative care model, which is better care coordination via integration of mental health and primary care, which has been shown to improve patient access and outcomes. So starting in January 2017, CMS approved payment for psychiatric collaborative care programs and behavioral health integration services. So the 3 core elements that make up the collaborative care model are care coordination and management by a social worker or psychologist working with the primary care provider, regular proactive outcome monitoring and treatment throughout the use of standardized outcome measures and technology, which I thought was really interesting because they really stress this idea of like standardizing and also being proactive about it. And then the third one is regular psychiatric patient case reviews with a psychiatrist or professional with psychiatric training whose primary responsibilities are making treatment recommendations, which you can see in this nice graphic.
That's really fascinating. And one thing I wonder about, if you wouldn't mind going back to that last slide, is I wonder how, let's say, so I really feel like a rate limiting factor on a model like this is the primary care provider's time. So let's say they have a panel of 2,000 patients. It seems like they would not have, if there are 2,000 work hours in a year, they would probably not have time to review each patient with the psychiatrist. So I wonder how they would prioritize which are the ones who need a case review and which are the ones who are probably fine. This is, I wonder about that.
Maybe there would also be maybe that's why you also have the other, the care manager and the social worker, it's not just the primary care provider and the psychiatrist, right?
And the care manager could be the one who maybe helps prioritize. Yeah. That is the care manager's job in general, is to prioritize who are the people who need proactive outreach.
Right.
Okay.
And I think the work of prioritizing is actually the main work in the collaborative care. One of the challenges that a lot of articles highlighted is that there were just not enough workforce to execute this. So the worker burnout and those things were a big challenge to overcome.
Absolutely. And not to toot the analytical IQ horn too hard here, but that's literally one of the main functions I'm doing for a client right now, is helping their care managers prioritize who to target first. And so we can use data to speed up their workflow.
Yes, analytical IQ. All right. So as we are already talking about, I guess, how there are some downsides to this initiative. There are many administrative hoops to to jump through, and the existence of CMS copays will have an impact on low-income patients' ability to receive care. And there was also the issue that Adam actually pointed out of sharing patient information between providers, and how the federal government regulations for privacy in behavioral health care are much more strict than in physical healthcare. So there would need to be some addressing of the privacy guidelines as well.
All right. So another model is the accountable health communities model. We vaguely know that social determinants of health, behavioral health, physical health, they're all connected. But we want to see how well this holistic approach works. That's exactly what the government did. So starting from May 2017, CMS has funded the infrastructure and staffing needs of the so-called bridge organizations that aim to close the gap between clinical care and community services. And that includes housing, food, utilities, transportation, or even violence intervention programs. So these bridge organizations partner with clinical delivery sites and community service providers to screen Medicare and Medicaid beneficiaries for their unmet health-related social needs. They refer and connect the beneficiaries to community service providers, and they also work to align the partners to optimize their capacity to address the health-related social. AHC can be an example of a model that tackles all three aspects of integrated behavioral health care by directly connecting the organizations that address social determinants of health and those that provide clinical care. They make behavioral health care more known to the general public. They help treatments take place. And in the process, they align the way that different providers work with one another. Currently, there are 29 bridge organizations enrolled, and the first federal evaluation is coming out 2022. But at the Early Insights Conference in May, though, the participants reported how tackling region-specific problems such as food quality surprisingly improves the health outcomes and reduced healthcare costs. Maybe not so surprising, but they surprisingly found out that. Some challenges were brought up too, including challenges about addressing rural populations or the general lack of trust about information sharing, like Syamala mentioned. So the participants went home with strategy recommendations, and we'll be able to see how well the AHCs have done in a couple of years. So behavioral health has a documented history of stigma and misaligned incentives where patients get sicker and providers lose money. We've seen how the patient, payer, provider can actually be in this win-win-win situation in behavioral health, and how positive outcome in behavioral health significantly impacts physical and overall health. And we're also seeing how government can play a big role in rectifying this chronic vicious cycle by enforcing and implementing integration programs. So we must say that it is up to the government regulations and initiatives to help mitigate the behavioral health hole that we have dug ourselves into.
And of course, behavioral health is an evolving discipline, and there will always be more improvements to make and more questions to answer. But for now, the behavioral health system is, again, like Hyunmin said, severely stigmatized, while simultaneously being one of probably the most important investments our society and government could make in our health, safety, and future. For now, we can say that an effective government which creates policy and initiatives while fighting to end stigma against mental health care are two essential ways that we can make change.
Awesome. Well, thank you guys.
Yeah.
I'm just curious, and anybody who wants to answer this, feel free. Can you just share a little bit about what was the most maybe like surprising thing you learned during this this exploration? Because you guys spent 2 weeks. Like, I've seen your research doc. You guys went super deep on this topic. So maybe what were some of the kind of surprises or insights that you didn't expect when you got into this?
You can go first.
You said I could go first?
Yeah, I thought you were going to.
No, put me on the spot, Hyunmin. No, I'm just kidding. I guess, like, in terms of surprising, or like, first of all, I think I was surprised by like the sheer number of like actual government like sponsored programs that are like happening, and like, or that they're like trying, even if like there are like some from like a few years ago that probably like just aren't around anymore, or like they're not using them, or but like the fact that they've been like churning them out kind of, and like it's always like behind the scenes and we don't really like know about it unless you're for like in healthcare. Like, I don't know. Yeah, that was surprising to me because I thought, I don't know, I was under the impression that like government was way less hands-on than it actually is, which is kind of like hopeful for me. But yeah, and that, and like also just like learning about like how even the fact that the incentives are misaligned in behavioral health, it like it's still like not a simple thing to talk about. Like even, I don't know, like when Hyunmin was talking about just like profits, like short term versus like long term and years of life lived and like all of these like different factors, like it just continues to kind of like, I guess, surprise me like how much is going on and like how much more there is to like know about, I guess. But
What about you, Hyunmin? What sticks out from what you learned over these past couple weeks?
I think one big thing is how much I was surprised by how big the problem was when we first considered mental health as a topic. I don't know how Syamala was thinking about it, but I was thinking about it as like an interesting topic that, it's largely neglected. So it would be like an interesting, like, hey, you didn't know about this kind of topic.
But like appropriately narrow.
yeah.
Yeah. But as we
How funny.
we realize how big of a problem it is and how interconnected it is. And even if it's not like 100% interconnected, like the issues in behavioral health and the cost that incurs itself is way bigger than any other types of healthcare. So that made me realize like how important this topic was. And I think that was the biggest surprise point. I think I was in disbelief for like the first half of my research, and then, like you kind of have to like take it in. So yeah, it was definitely like a process of developing a new perspective of what health looks like and what healthcare should look like. So for me, it was very educational.
I was actually going to say also, sorry, one more thing.
Go ahead.
Just like the definition of behavioral health also, like, or just like the fact that it's called behavioral health and not mental health, like that was actually like really shocking for me too, because I feel like that's like a really basic thing. But like, I don't know, like how like mental health is just like one part of behavioral health, and like behavioral health actually covers literally so many things, like from substance abuse, but also like social workers and like community building and things like that. And like, I don't know. Yeah. And like, even right now we're seeing like lots of push for, like defunding of the police and like issues of like the Black Lives Matter movement, and how investing in behavioral health is like a proposed solution to helping like solve the issue of police brutality as well.
Yeah.
And
maybe behavioral health for police officers.
That too. Yeah. Or just don't have them. But yeah, that's
awesome. I really appreciate the work you guys did on this. I was curious, I mean, and each of you might have a different answer to this. Do you want to go deeper on behavioral health, or do you want to switch and look at something else? Are you tired of it?
To look at
I don't really have an opinion on whether we should pursue this topic further or not. I think the answer would definitely depend on like what other options we have.
Well, so let's talk about that. I'm going to hit stop on the recording. Hey everybody, real quick before you go, just want to thank you again for watching. If you're not already on the Analytical IQ email list, then you might want to consider it. You'll get an email every time we release a new video like this one. And I personally read and reply to every response I get on the email list. So if you have something that you want us to examine, to take a look at, to ask a healthcare analyst, then the